So for my 5 minutes of glory, I decided to talk about treatment consideration in brain tumor-related epilepsy, partly because neuro-oncology may not have such an educational cover, and you might find it interesting. Nothing is moving. Here we go. So when I look at brain tumor-related epilepsy, I found this imaging quite appropriate. Although on the outside they may look identical, actually anybody knowing them is aware that there are two nosological entities. Just through a quick look of the literature, you may think that brain tumor-related epilepsy has very clear focal characteristic, but most patients do present with generalized seizure. In comparison to idiopathic epilepsy, the percentage of refractory seizures is quite high, at least before surgery, and can reach 85%. Now, a long spell free of seizures does not really decrease the risk of seizures in brain tumor-related epilepsy, and this is because brain tumor underlying is playing a role. The vast majority of brain tumor patients do experience a prolonged seizure during their disease journey, and not necessarily at the end of life. And in terms of treatment, we have quite more ammunition that are routinely used and heavily influence seizure management. So not all is bad, and it may come to a surprise, but a brain tumor patient presenting with a seizure have a better prognosis than those presenting with other symptoms. And these notions open up the next slide, so where there is a two-way link between the tumor and epileptogenesis, because they do share metabolic pathways. You have heard about IDH mutation in brain tumors, and this is one of the markers that we analyze routinely because it predicts, is a prognostic factor for tumor behavior and response to treatment. Well, in IDH mutated tumors, there is an accumulation of 2-hydroxyglutarate, that is an excitatory neurotransmitter, and this is indeed the association where brain tumor, which are IDH mutated, are much more epileptogenic. If on one side chemo and radiotherapy do help, in the medium and long term, about seizure management, on the other side, we have clinical trials suggesting that valproate, for example, give a 2 to 3 months life advantage in glioblastoma, where life expectancy is 1 to 2 years. So that is quite a massive finding, even if there is a debate about possible bias in these trials because seizures were not the primary outcome. So, final slide. We reach the conclusion. When the neurologist is faced with a patient with brain tumor-related epilepsy, what are the additional considerations that would be good to keep in mind? So, tumor location. Levetiracetam is a great drug, is liked by clinicians across all disciplines and patients alike. Still, 8 out of 10 patients with a frontal tumor do experience psychiatric side effects requiring changing medications. Tumor type, glioblastoma, we have seen and mentioned before about valproate, where there are some laboratory findings that would suggest that the clinical trials have some truth in saying that they give valproate give life advantage. Tumor grade. So this is a slide from one of the published studies, and we know that aggressive tumors above grade 2 are linked with an expression of anti-drug resistant proteins on the blood-brain barriers, which decrease the amount of some of the antiepileptics, for example, lamotrigine and carbamazepine. Consideration for the type of surgery, but also on chemo and radiotherapy for the risk of cognitive effects, which might be exacerbated by certain antiepileptics, but also for the risk, for example, of skin toxicity and acute toxic necrolysis for antiepileptics that do have a skin side effects. So, and with this, I think I've finished my 5 minutes.